Welcome to the Nebraska Pharmacy Technician Certification presentation specific to the pharmacy audit and compliance. This presentation focuses on Medicaid payer compliance, although the concepts within the presentation can be carried through to really all third-party payers such as Medicare and private insurance companies. The objectives that I will cover today in the presentation are to describe the process for audit selection and review. This is an explanation of why is your pharmacy or why is an individual pharmacy chosen for audit, to define fraud, waste, and abuse, list examples of Medicaid program noncompliance, and then talk about ways to prevent or be proactive with the noncompliance issues. Number 4, recognize the importance of documentation and following provider guidelines set forth by the payer. And then number 5, describe how to report suspected fraud within the pharmacy. An overview of the items we'll cover in this presentation. First of all, we'll take a look at audit mandates. This will give us an idea of the different laws and regulations that mandate the ability for an entity to come in and audit the pharmacy. Why me? Audit selection. Why is your pharmacy being chosen for audit? Common audit findings and what to expect during the auditing process, and some tips on how to work with the auditor. And again, some proactive steps to decrease the audit findings of noncompliance, and then how to report suspected fraud, waste, or abuse. I think it's important to first talk about the basics of where do audit mandates come from. Why is a third-party payer allowed to come into the pharmacy and look at records and perform an audit? So to start out the conversation about pharmacy audit, we'll take a look at a couple of federal laws, the Social Security Act and then the False Claims Act. So the Social Security Act, there's a certain section called the Deficit Reduction Act, and that provides states with much of the flexibility to make significant reforms to their Medicaid programs. There's a section within the Deficit Reduction Act that addresses fighting Medicaid fraud and abuse. Fraud and abuse in the Medicaid program divert dollars that could otherwise be spent to safeguard the health and welfare of beneficiaries. The False Claims Act is also a federal law that imposes liability on persons, entities, companies who defraud government programs. There's a section within the False Claims Act called whistleblower protection, and what that means is that if an individual in good faith reports suspected fraud, there's a certain type of protection within that whistleblower protection clause for the person reporting the suspected fraud. So along with the couple of federal laws that I just talked about, there's also specific state pharmacy law that would be in the state statutes. There's also regulations within the third-party policy and procedure manual, and then there is specific Medicaid regulation. As an extension to the previous slide, this slide gives a little bit more understanding about third-party policy and procedures. So each third-party payer that the pharmacy has a contract with for reimbursement has a policy and procedure manual that lists contractual guidelines for the providers to obtain reimbursement. So the provider is the pharmacy is providing the service, providing a product. The third-party payer is the insurance company or Medicaid entitlement, Medicare. The manual contains a statement of the right to audit similar to what I have listed here. So the payer or its delegate has the right to inspect, review, audit, and obtain copies of the pharmacy's prescription files, signature logs, and records. Claims submitted by the pharmacy and adjudicated by the pharmacy are subject to desktop and/or on-site audit. Incorrectly submitted and adjudicated pharmacy claims may result in an adjustment. The payer will recover overpayments identified through the audit. The pharmacy's refusal or denial to submit to and/or comply with the payer audit process will result in a total chargeback of paid claims. Failure to comply with the payer audit process may also result in suspension of payment and/or possible termination from the network. So I think it's important to to kind of start with this basis to understand, again, where the audit process starts from and why it's happening. So there's a contractual obligation between the payer or the insurance company and the pharmacy, also known as a provider. The payer says in that contract, okay, we will reimburse for the medication that you dispense to the patient, but these are the guidelines, or this is the map to how we will reimburse. And so those are a lot of the elements that we're going to talk about in the presentation moving forward. So along with the individual third-party payer policy and procedure guidelines, there's also state law, and this slide shows state law specific to Medicaid in Nebraska. So Medicaid programs are managed on a state level. It's a partnership. Medicaid is a partnership between Centers for Medicare and Medicaid and the state, but managed on a state level. So the Nebraska provisions actually say all services for which claims for payment are submitted to the department, this meaning the Department of Health and Human Services, which is Medicaid, are subject to audit. During a review audit, the provider shall furnish to the department or its authorized representative pertinent information regarding claims for payment. If an audit reveals that incorrect payments were made or that the provider's records do not support payments they have made, the provider shall make restitution. And as we move through this presentation, we'll talk more about what that restitution is. We'll talk a little bit more about overpayments, just to give a general understanding of the audit process. This slide discusses the workflow when an audit happens within your pharmacy. Some of the things happen before the auditor will even contact the pharmacy, such as the third-party payer selects pharmacy for audit. So when this selection happens, and we'll talk about why the pharmacy may be selected for audit, but when the selection is happening, the pharmacy is not aware at this time that they will be audited. So that's something outside the doors of the pharmacy. An algorithm is used to distinguish random sampling from claim universe. We'll talk more about what is an algorithm, what does random sampling mean, but that's part of the process of how the pharmacy is selected for an audit. Some steps are, this is a simplified version. There'll be some communication steps in between here, but another broad step is that the pharmacy sends requested records to the auditor or auditing company. The auditor or auditing company then reviews the records, and what happens during that review, partially what happens, is that the records from the pharmacy are compared with the third-party payer data to see if they match up, to see if the records are accurate. And then a report listing non-compliant findings is shared with the pharmacy. The pharmacy has a chance for rebuttal of those records. The pharmacy has a chance to appeal what the auditor found in the records. And then one of the last steps then is recoupment, and so that means that if there's an overpayment, the third-party payer, in this case Medicaid, will communicate with the pharmacy to recoup whatever dollars were overpaid. So let's take a moment to talk a little bit more about audit selection. Why is your pharmacy or my pharmacy chosen for audit? So any Medicaid provider, and remember provider is our term for the pharmacy, any Medicaid provider can be selected and may be selected for audit. So there are different triggers in some cases for an audit. So examples of data analysis issues that trigger a pharmacy for audit, such as inappropriate use of codes or payment submission. A high claim volume, if the pharmacy has a high paid amount with a Medicaid or other third-party payer. A high refill rate, high ingredient costs, some outliers. And what I mean by outliers is that within Greater Omaha area or within Nebraska, this seems to be the norm for reimbursement for a certain drug. But this pharmacy has an outlier. They're being reimbursed, or they're being reimbursed at higher amounts. Now Medicaid has a set paid amount, but higher amounts meaning that they have many more claims than other pharmacies for the same medication. Another trigger that's looked at when there's a data review is that there may be a noted change in paid amount from year to year. So for example, if Medicaid paid the pharmacy $3 million in 2013 and then in 2014 paid the pharmacy $13 million. So that's absolutely a noted change and will probably could be a trigger for an audit. So Medicaid audit involves both Centers for Medicaid and Medicare Services and states working together to identify issues and providers for the audit. And again, that's something that's done behind the scenes that the pharmacy won't know about. The provider, again, can be selected through data analysis, and we just talked about some of the data triggers that might trigger an audit. There also might be a referral from patients where they suspect something's not quite right with the pharmacy, or there could be a referral originating from pharmacy staff. Now that we've talked about how a pharmacy may be selected for audit, let's move into the next step. After the pharmacy is selected for audit, the pharmacy will be notified by the auditor or auditing company, and then the pharmacy and the auditing company work together to start to look at records, and the pharmacy is chosen for an audit period. And it's a proactive audit, meaning that right now we're in 2016, and so the audit will be for the year 2014. And so if we take a look at 2014 and all of the Medicaid claims that went through the pharmacy, there's really just too many claims to audit each and every one of those claims. So therefore, the next step after that pharmacy has been chosen for audit is to determine what group of claims from that year will actually be audited. So paid claims are selected from a universe. So that universe will be all of the claims that were submitted to Medicaid and paid on for the year. So there's an algorithm that's used, stratified random sampling, and then the audit results are projected by extrapolation. So those are probably some different terms that we haven't used before. So I just want to take a minute to kind of define them. An algorithm is an automated formula or series of rules scaled against Medicaid claims data to detect abnormal transactions of potential overpayment or underpayment. So a focused algorithm can be applied to focus on certain audit criteria. A random selection of claims from the pharmacy claim universe, and those claims are arranged into a strata. Again, some different terms, but what we're trying to do here is produce an unbiased result reflecting the diversity of the universe or the population of claims that's going to be representative of that entire universe. Audit results are projected by extrapolation. So extrapolation is something that comes actually at the end of the audit. It's a method of using a mathematical formula to take audit results from a small number of paid Medicaid claims and project them back over onto the large universe of claims. So again, we take that universe of claims, and maybe there's 13,000 claims, and we need to make that universe smaller by using an algorithm and a stratified random sampling. We want to make it smaller and more obtainable to be audited, but really have a reflection of that entire claim sampling. Moving forward from the previous slide where we discussed how records are selected for review, this slide will discuss what the auditor actually looks for in those records. So hopefully getting this information will help you as a pharmacy technician in your daily workflow, not only to safeguard your pharmacy from overpayment, but to also safeguard the Medicaid program, and also to just help prevent findings when your pharmacy is chosen for audit. So the auditor provides a verification of efficient and appropriate use of the Medicaid dollars, and really looks to preserve the financial and operation integrity of the Medicaid program when this audit is performed. So, auditing for accurate payment of claims, the auditor will look that the drug billed for is actually covered and on the preferred drug list. An example of this is an over-the-counter medication that isn't covered by Medicaid. If a claim slipped through the cracks somehow and was paid for an over-the-counter drug, this may be a finding for the pharmacy if it's not on the Medicaid preferred drug list. The medication also needs to be approved by the Food and Drug Administration to be reimbursed by Medicaid. Medication needs to be within the federal and state rebate agreement. The same drug dispensed to the patient needs to be the drug that was reimbursed for, and the same quantity the patient received needs to be the quantity that was reimbursed for. So let's take a look at the bottom 2 points here and talk about them, and I just will give you a couple of examples to help with understanding. So the auditor will look at a couple of records to verify that the drug that was billed to the Medicaid program was actually the drug that was dispensed to the patient. So the auditor will look at the label, a copy of the label, will look at a signature log, and will also look at data from a computer printout screen. Auditors can also look at inventory records from the pharmacy to make sure that the pharmacy actually had the medications in stock to dispense to the patient. The last point in this column, same quantity patient received, items that the auditor will look at or records would be, again, that signature log to make sure that the patient received the medication, and then the label to make sure that that amount dispensed and billed for was what the patient received. Auditor will also make sure that the claim includes a valid prescription. There's different elements that make a prescription valid. For instance, the prescription needs to be signed by the provider or the prescriber, and if a prescription is for a controlled substance, there'll be other elements that make it valid. Refills have to be authorized by the prescriber and follow the threshold rule. So the threshold rule, most payers, it's a 75% threshold, and what that means is that the patient needs to have used 75% of their medication before a refill can be paid for by the third-party payer. Also, there should be a pedigree in place, and this is new legislation that passed just recently in 2015 that says that all medications must have a pedigree. A pedigree is a document that follows the medication from the time it's manufactured through going to the warehouse and then arriving at the pharmacy and dispensed to the patient. It follows the path of the medication to make sure that the medication has not left the supply chain, and if leaving the supply chain, there's a chance for counterfeit medication and a risk for the patient not having the appropriate medication. So common audit findings include some of these items listed on the slide, and again, I think it's important to know what common audit findings are. That way you can prepare within your pharmacy and your workflow to make sure that you are complying with these elements. So a common audit finding is that the drug isn't covered, it's not on that provider or the third-party payer's preferred drug list. It might be an invalid prescription. Again, this is common. Some different elements that make the prescription invalid is that there's not a prescriber's signature, or that refill is not authorized, the prescription is not authorized. I think sometimes this happens with telephone orders. So a telephone order is legal, but there needs to be some elements included in that order so that it's valid. Unauthorized refill, sometimes a pharmacy may automatically refill a medication when it's not authorized. Sometimes, especially when we're looking at long-term care, the refills are automatically happening every month, and we need to make sure they're authorized from the provider or prescriber. An overbilled quantity. So there's a certain amount that the prescription allows for the patient. There's a certain amount that the third-party payer allows to be billed for as a month supply, and sometimes that's overbilled. The refill's too soon, again, that has to do with the threshold rule. And missing records, believe it or not, oftentimes an audit finding is that there are missing records. There is maybe not signature logs showing that the patient received the medication. The patient may have received it and hopefully received the medication, but we have no way to show that the patient received it. Missing signature logs. Sometimes prescriptions are actually missing. So accurate record keeping and organized record keeping is certainly an asset. So with the slides and with the presentation, I'm trying to follow a natural progression of the audit workflow. We've talked about how records are selected for review, how the pharmacy is selected for an audit, what the auditor actually looks for in those records, and some common audit findings. And now we're going to take a look at this slide on audit outcomes. So overpayment is the amount paid by Medicaid to a provider, and again, provider is pharmacy, which is in excess to the allowable amount. So if there's findings, so let me give you an example of an audit finding. There is a claim that Medicaid reimbursed the pharmacy for, and there's no prescription to authorize dispensing that medication. And having no prescription would be an example of missing records. So therefore, since there's a missing record, there's no prescription, that is an overpayment by Medicaid because the pharmacy is not authorized for that payment without the actual prescription. So what happens is the state Medicaid agency collects that overpayment from the pharmacy, and then the state Medicaid agency in turn refunds the federal share of that overpayment to centers of Medicare and Medicaid. Okay, so let's take a minute to just talk about what to expect when your pharmacy is chosen for an audit. So first of all, there'll be initial contact from the auditor or auditing company. There'll be both entrance and exit conferences between the pharmacy, the state Medicaid agency, and the auditor. And as we talked about before, the auditor or auditing company will request documents or records from the pharmacy. Whether it's a desk audit or an on-site audit, there will most likely be interviews with pharmacy staff. And understand that this is normal. It doesn't mean that the pharmacy has done anything wrong. It's just a way for the auditors to gain an understanding of the workflow with the pharmacy. Sometimes the auditing company will send out a questionnaire rather than a verbal interview. There will definitely be deadlines for the pharmacy. Deadlines to submit records, deadlines to respond to questions, a lot of communication between the pharmacy staff and the auditing staff as well as the Medicaid agency. And again, there's a couple of different kinds of audits. There can be a field audit, which is an on-site audit. The auditors will come into the pharmacy. Most often this is not unannounced, rather an appointment is set at a time where pharmacy staff or a member of the staff can be available to assist the auditors. There's also a desk audit, and this is where the pharmacy may not see the individuals. The records are sent electronically. There can also be a combination of both a field and desk audit, where auditors present to the pharmacy in person, and they also audit records off-site. And then there's absolutely a report of outcomes on what was determined through the audit. So tips to work with your auditor: ask questions and communicate with the primary point of contact. Make sure to gather the requested records. It's in the pharmacy's best interest to gather those records and organize them and supply them to the auditing company. Include supporting documentation with the record request. So if there are handwritten notes to go with a claim, make sure to include those, because that tells the pharmacy's story of how that claim was submitted and paid for. and certainly adhere to time frames for the deadlines and document submissions. So this slide talks about some proactive steps that you can take as a pharmacy technician to help decrease audit findings within your pharmacy. It's important to document, and I know that the pharmacy workflow is busy, but by the end of the day you may not remember why you did a certain step. So documenting at the time that the claim is processed is a good idea. To definitely have an organized record-keeping system. To submit accurate claims, know the third-party payers formulary, their preferred drug list, and really take a look at denials when they come through. I think sometimes we get in the habit of automatically putting in a code to override a denial, and that may not always be the best idea. The denial may come in legitimately. Maybe the drug is not on the PDL. Maybe the refill amount is over the threshold. And rather than putting in an override code automatically that may get us in trouble later, it may be worth the time to investigate that denial. Some other suggestions for proactive steps are to talk with your software vendor about updates that are going to include payer regulations and payer policies to help alleviate a reimbursement that shouldn't be happening. A standard operating procedure for telephone orders. Oftentimes some of the non-compliant prescriptions or non-compliance with reimbursement comes into play with a telephone order that doesn't have the elements needed to be a valid prescription. Also, signature logs are an item that seem to be a problematic area for some pharmacies. So to really have procedures in place to make sure patients sign the signature log when they have a delivery that's outside of the pharmacy, and definitely when they're coming in to pick up their medication. Staff training on these steps to be proactive, and just open communications between staff members within the pharmacy and managers, and to really have knowledge of state, federal laws and payer rules and regulations. The next few slides are going to discuss fraud. And so what I wanted to do with this slide is just define fraud, waste, and abuse. Fraud is the intentional deception or misrepresentation made by a person who has knowledge that the deception could result in unauthorized benefit to himself or some other person. The key word to fraud is that it's intentional, it's knowingly and willfully misrepresenting some type of practice within the pharmacy that would result in fraud. Waste then is different from fraud, is that it's overutilization or inappropriate utilization. It's usually not intentional. And then abuse is provider practices that are not fiscally sound, reimbursement for services not medically necessary. And abuse can also be beneficiary practices or the patient practices. It isn't just within the pharmacy, but it can also be the patients who are involved in a fraudulent or wasteful or even an abuse tactic. So moving on from the previous slide where I defined fraud, waste, and abuse, I thought it would be helpful to identify some common types of fraud, waste, and abuse within the Medicaid program. Ghost patients are certainly something that we could see in pharmacy, and this is where the person picking up the medication or the person who the medication is dispensed to is really not a person. It's a made-up individual, and most often medications are not even dispensed, but it's a way to gain that reimbursement money, a fraudulent activity. So medications aren't dispensed, the patient doesn't exist, but Medicaid is billed for the medication and the pharmacy receives payment for that. Medical identity theft is something that can happen through beneficiaries or through a pharmacy, and what that is using the identity of an individual and saying that individual is a patient when they really aren't, and then receiving medications or using that patient information to bill for medications, and maybe the medications aren't received. Billing for unnecessary services and items, billing for non-covered services or items. Upcoding is something that we don't see in probably in an ambulatory pharmacy. We may see that in a home infusion pharmacy, maybe an inpatient pharmacy. Upcoding is more common with medical practices, but what that means is that different procedures have a code that's assigned for billing. One of those procedures that I can think of with pharmacy is medication therapy management. And so upcoding would mean there's a certain code assigned to a 30-minute MTM visit. Upcoding would be to bill for a 1-hour MTM visit by assigning the 1-hour code. Unbundling, again, something that isn't going to be customary, probably in an ambulatory pharmacy. Unbundling is where services are bundled together and offered at a less expensive rate. And when, let's say, those 3 services are unbundled, each service individually costs more, and then the payer is billed more. To help explain that, I'm probably not being really clear, but let's say there's 3 services, and when those 3 services are bundled together, the cost is $200. When the services are offered alone or unbundling, they're $100 a piece. So unbundling services leads to a higher reimbursement rate. Kickbacks and beneficiary fraud, I think, are self-explanatory as part of common types of fraud, waste, or abuse within the Medicaid program. So as a pharmacy technician, you're certainly able to report suspected fraud, waste, or abuse to either the State Medicaid program or the Office of Inspector General or a Medicaid Fraud Control Unit. So within here I have a link to the state reporting agency as well as the OIG, which is the National Reporting Agency. And again, please keep in mind that this is a report of suspected fraud, waste, or abuse. It's not our position as pharmacy staff to investigate and be definitive. Deciding if fraud has been committed is up to the legal system and the courts, but this gives an avenue to report suspected fraud. So the final slide, I wanted to summarize some steps that you may be able to help put in place for best practices to prevent overpayment or prevent audit findings. The staff exclusion status before hire and at regular intervals. I have an exclusion link within the resources of this module. And what the exclusion is, it's a list of excluded individuals or entities within the healthcare industry. And these are individuals that are excluded from participation in Medicare, Medicaid, and all other federal health care programs. Staff professional license and registration to make sure that you have the state registration with Nebraska, and now the certification very soon will be required, so make sure that that's up to date and has been renewed. The vendors, these are the entities that deliver medications to the pharmacy, such as McKesson or AmerisourceBergen, or maybe there are some other companies where medications are purchased from. Those vendors all must be licensed with the state in order to do business within the state. The prescriber name matches their NPI number and DEA numbers, and that there's drug pedigrees in place. So those are part of the verification processes that can take place to help with prevention of overpayment. An internal audit can help too, just different spot checks, and then taking a look at maybe some oversights and what can be done to correct those. Determining if there's maybe additional safeguards that should be in place. Certainly staff training, knowledge of policy and procedures within the pharmacy, as well as policy and procedures for third-party payers. Open communication, and again, documentation is key. And then the workflow, making sure that the signature logs are there, taking a look at procedures for telephone orders and documentation of refills, and that the medications dispensed are those that are authorized. Really some of the common sense things that we do in pharmacy every day, just to make sure that there's steps in place to ensure that they're not overlooked. Thank you.